Welcome back to our afternoon at ICPLP. We're going to start with a half-hour poster session, and then directly after that we're going to go to an oral session. Enjoy! And we're ready to hear our first presenter. Thank you very much.
Thank you, and good afternoon. Thank you for having me to speak at this exciting first Phantom Limb Pain conference. My name is Holly King, and I'm a clinical specialist physiotherapist working in private amputee rehabilitation in the UK. For many years, I've seen that the most common and obstructive issue to successful amputee rehabilitation is pain, and particularly phantom limb pain. Those suffering also struggle with exhaustion, loss of concentration, and depending on the severity, it can severely delay or even halt their recovery. Clinical experience made me acutely aware of the detrimental side effects from use of long-term prescription medication. With the postgraduate training in Western medical acupuncture and a background in musculoskeletal physiotherapy, I looked to find a non-pharmacological management strategy. Acknowledging that some external factors may exacerbate an amputee's phantom limb pain, I recognise that there are significant biomechanical changes that take place locally at the severed nerves post-amputation. I explored dry needling in the lumbar paraspinals between L1 and L5 and in the residual limb, and you can see from the photographs the landmarks of the PASISs and the bottom of the ribs for your reference. Unfortunately, I found that the outcome with dry needling was marginal and any reduction in pain was very short-lived. So I went on to explore applying electroacupuncture to the same points to increase the intensity and effect, and discovered a much greater and longer lasting relief from phantom limb pain. In my recently published paper, I've taken one case study from my clinical practice to highlight the positive outcomes of electroacupuncture, but I have many more in my successful cases. The case study is of a patient 7 months post-traumatic transfemoral amputation with severe and uncontrolled phantom limb pain that consumed all parts of his recovery and disturbed his sleep. He had minimal relief and significant side effects from pharmacological medication and had tried graded motor imagery, education, and sleep strategies with minimal benefit. After 3 months of weekly electroacupuncture and then periodic 4 to 5 weekly top-ups, he had significant reduction in his phantom limb pain severity, frequency, and duration, as demonstrated by the downward trajectory of the graph. He was able to stop taking his pain medication and was able to sleep 7 to 8 hours a night, whereas previously he'd only managed a couple of hours a night. His prosthetic use and function also significantly improved from a few hours a day to full time. At 12-month review, he'd only a mild phantom limb pain occurring less than once a week. Our paper proposes that neuropathic phantom limb pain chronicity may be prevented by eliminating the peripheral nociceptive stimuli using electroacupuncture. Evidence is growing that there is a positive correlation with high-dose acupuncture and positive outcomes. And since this case study, I've increased the time of each electroacupuncture treatment to 60 minutes and increased the intensity, which has given even better results. This case report is important as it shows for the first time that an easily reproducible electroacupuncture protocol is effective in reducing phantom limb pain in amputees. And we hope that electroacupuncture will be taken up by other healthcare professionals as a simple and very effective treatment for phantom limb pain. And if you're interested in exploring this further, please do email me. And thank you for listening.
Thank you so much. And then we're ready for our next speaker.
Okay. So, hi everyone, Mariama Dione. So here we propose to use the technique of microstimulation in a large group of non-amputee individuals, here 20. To explore the sensory percept that one can elicit with electrical stimulation of the peripheral nerves. So the final aim was to provide general guidelines that could help setting up sensory feedback in amputee individuals equipped with advanced prosthetics. So the classic technique of microstimulation consists in inserting a thin needle near nerve fibers to stimulate single fibers electrically and to report the percepts obtained. So here we try to mimic the stimulation as it is done with advanced prosthetics, hence stimulating the entire nerve rather than single fibers, using low impedance electrodes, and observe and try manipulate the percepts obtained. So our strategy was to insert our needle down to an intranual location and then to retract it progressively up to several extranual locations. So this is actually mimicking the different types of electrodes used in the field. At each location, the participant was asked to describe the percept using the Valbo test. So we will draw the percept on a representative hand map and report its size, borders, naturalness, etc. So here you can see the percepts that we obtained in this study. So most of the obtained percepts were very large in size, contrary to what is usually obtained with single fiber microstimulation. The size of the percept tended also to increase at external location, but small as well as large percepts were found at all locations. So borders, naturalness, etc. did not vary with the electrode location, and the main sensation was pins and needles. We also varied the electrical parameters to try and manipulate these percepts. So, for example, drastic changes were obtained when we switched the polarity of the stimulation between positive to negative currents in most cases. When we varied the frequency, no change was obtained in most cases. Finally, when we varied the pulse amplitude, very systematic changes in size and intensity of the percepts were reported. These results, along with others not reported here, show how microstimulation can be used to define strategies of electrical stimulation. We think that selecting the appropriate parameters to define sensory feedback that flexibly matches the properties of the object touch may improve prosthesis and embodiment and maybe help reducing phantom limb pain in amputee individuals. Thank you very much.
Thank you very much for your presentation. And with this, we are looking forward to hear the next poster speaker.
Okay. Okay, so good afternoon, everyone. I'm Eugenio Scaliti from the Italian Institute of Technology. And as you know, many awesome talks in these 3 days showed us that phantom motor execution can be a promising task for the treatment of phantom limb pain. With the present studies, we explore the nature of and the mechanism underlying the phantom arm movement. In particular, we quantitatively analyze the phantom arm movements at kinematic and muscle level. To do this, we use the phantom mocap approach, in which we use a motion capture system with retroreflective markers placed on intact arm or stump and superficial electromyographic recordings. While phantom arm movements cannot be tracked directly, phantom trajectory and velocity can be measured indirectly by tracking interference effects induced by phantom movements on the intact arm movements. We use the spatial coupling task, asking two patients to perform two different conditions. In the congruent condition, they draw a line with the phantom and the intact index finger at the same time. Differently, in the incongruent condition, they draw a circle with the phantom index finger and a line with the intact index finger. We calculated the ovalization index, the K-index, at a single trial level by fitting an ellipse to the trajectory of the intact index finger. Results show that for both healthy subjects and transradial amputees, the ovalization index calculated on the intact index finger was higher during the congruent than the incongruent condition. Moreover, analyzing the movement of the stump, we excluded that this coupling effect could be due to the stump movement. So we are sure that this coupling effect was due by the phantom movement. The muscle level refers to the pattern of muscle activity required to produce phantom movements. We used high-density electromyographic patches to record the spatial metrics of stump muscles during 14 phantom hand and arm movements. Two 64 electrodes array were used. One was placed on the extensor stump muscles and the other on the flexor stump muscles. The 14 movements were wrist extension and flexion, hand open and close, extension of each single fingers, and the flexion of each single fingers. Results showed a specific spatial pattern for each single movement. Now we are analyzing how the kinematic and electromyographic abilities are correlated with the phantom limb pain. In conclusion, these results have both theoretical and clinical importance. From a theoretical perspective, they suggest that phantom limb movements are best conceptualized as real movement of a dematerialized arm rather than motor illusions. From a clinical perspective, phantom limb movements may be important for developing new methods for phantom limb pain treatment and hand prosthesis with more intuitive control. Thank you very much to all of you and to the organizers.
Thank you very much for your presentation. And now we're happy to hear from the next speaker.
Hello everyone, my name is Monika Pilch and I am based in Trinity College Dublin. Welcome to this presentation on the interplay between innovation and intersubjectivity, which focuses on how therapists providing phantom motor execution therapy describe and explain change. This study aimed to explore subjective experiences of delivering PME therapy, and therapeutic alliance was of particular interest in the study. We used a qualitative approach and a framework method to identify meanings attached to the PME treatment. We recruited 11 therapists and used semi-structured online interviews to collect data. The interview guide was informed by a framework of contextual factors modulating therapeutic outcomes. Therapists described change that occurred within a complex three-way interaction between the key actors: a patient, a therapist, and the technology. Change was multidimensional, and innovation prompted change not only in patients, but also in therapists. Therapists considered diverse conceptualizations of success and highlighted the role of outcomes alternative to pain reduction. Perceived change and mechanisms of action enriched those initially hypothesized for the PME. Therapists identified the role of intra and interpersonal factors in modulating primary outcomes. Specifically, they felt that there is a need for patients' insight and their understanding of pain mechanisms and the architecture of movement. Motivated and cognitively competent patients, as well as experienced and committed therapists, contributed to the success. In the views of therapists, PME treatment should be customized to patients' needs, preferences, and characteristics. They observed a very interesting bidirectional relationship between therapeutic effects and external context. Therapeutic relationship was a platform that facilitated therapeutic change. Communication was important as PME intervention was embedded in talks, conversations, and verbal and non-verbal instructions. The therapeutic work was described as a real collaboration between the three actors, although power relations were present. Changes took place in time, and the length of therapy created opportunities for bonding. However, its development and nature was influenced by the structured protocol. Therapists offered expertise-informed adaptations and adjustments. However, overall, they felt that PME had the power to overcome disability and increase access to unique symptom reduction opportunities. We concluded that PME can impact on multiple psychosocial outcomes, even if pain reduction was not achieved. We need to understand mediating and moderating factors in order to advance rehabilitative efforts. To optimize therapeutic outcomes, we must consider patient profiles, including their cognitive skills. The content and function of communication between the key actors requires particular attention. PME can empower both patients and therapists, as it is able to increase both actors' level of control and give them access to previously invisible processes. In order to leverage the power of this treatment, we need to draw on collective and interdisciplinary approaches and incorporate expert patients and therapist perspectives. Thank you very much for your attention.
Thank you very much for your presentation. And the next poster is presented in person by Lendaro. Please.
Good afternoon, everyone. So today I want to talk about a little bit more the home trial that we did using phantom motor execution. So as we've seen, phantom motor execution has been used in the clinic and on some group of patients. And after terminating their study at the clinic, some of these patients have asked to continue the treatment at home to get a device and to continue to manage their pain into everyday life long term. So we took 4 of these patients. We took 4 of these patients. We have followed them up for a year in their use, and we have conducted ethnographic interviews in collaboration with an medical anthropologist and user. We have defined the user type, the way they use their device. So the patients that we followed were 1 lower limb patients and 3 upper limb patients. And here you can see a little bit more the type of data that we recorded. It's not so clear, it's very tiny written, but like on the top left of every quadrant, you have the pain rating, and then you have on the bottom left, you have the treatment adherence. So out of like how much of the suggested sessions they did in percentage. And then on the right side of every quadrant, you can see the length of every session. So it's an histogram showing the length of every session. And you can see that, like, yeah, from this data, I think what I want you to take home is that it has been used mostly to manage their pain. And this is a little bit of the flow that we followed in order to define the user types. So we have done interviews, and then we have coded these interviews. We have tried to find common themes in, like, I don't know, how much they used it, the motivation behind, etc., etc. And we have found that we have 2 types of users, and the experiential user, preferring like augmented reality, and the goal-oriented user. And yeah. So like, the conclusion is that PME can be used independently at home to manage their pain, and characterization of user type can be used to develop better treatments. Thank you so much.
Thank you very much, Eva. And with this, we're ready for our next speaker online.
Hello, my name is Rainer Schultheis. I'm the Managing Director of Sophenos, and I'm very proud and happy to present here our 4-stage therapy concept for more gait stability and also less phantom pain for amputees. And yesterday, the first 2 phases, especially the surgical intervention, was already presented from Dr. Alexander Gadetto. And the surgical intervention brought with the method of targeted sensor innovation a renovated area where after a few months the amputee could authentically feel his lost foot. And what we're doing now is that we have developed a sensory feedback system, a modular system where it is possible then to get information from the ground. And I will give a little bit of insight of this process. You see here, the idea is that the rolling movements will be detected with sensors. We are doing it with a sensor sock. It's a modular system, as I told you, so you can implement it on an existing prosthesis. And this information then will be transmitted, radio controlled to a matrix of actuators, vibrotactile actuators, to the stump of the amputee. And there are different ways of doing it. So one possibility is to implement it directly into the socket of the prosthesis. You see here a transfemoral amputation or a prosthesis for a transfemoral amputee. It is also possible to implement it into a cuff. So there the actuators are in the cuff. You can use it there, for example, above a prosthesis. But other ideas, we also developed some sort of silicone pads or also liners where these actuators are waiting and getting the information from the sensor sock. And what we're doing then is also we have a digital application where not only the user, but also the orthopedic technician, when it comes, for example, for after sensor mapping to know exactly what is the right frequency the actuator should have to get the best sensitivity. So those settings can also be made. You can turn on or off several sensors. And what is also important, after the surgery, it is possible then that the amputee can then be get used to this vibrotactile stimulation. So there are certain modi, so he gets induced to this sensory feedback system. Thank you very much.
Thank you so much for your presentation, and we're ready for the next speaker.
Is that working? Can you see that okay?
Everything is okay here. We can.
Yeah, good. Thank you. So good afternoon. My name is Sarah Dixon-Smith, and I'm a final year PhD candidate with the Pain Research Group and the Centre for Blast Injury Studies at Imperial College London. Today I'm going to talk very briefly about one aspect of systematic review that we've been running, investigating chronic post-amputation pain in First World War veterans. There are a couple of good reasons I'll go through quickly for using the First World War medical records. The first is that there are so many amputees, but they're also the only lifelong military medical records that we have, that they're available to the public. And also the mechanisms and patterns of injury between the First World War and the more recent Iraq and Afghanistan conflicts are remarkably similar. So a blast injury from an IED has much the same effect on the body as a First World War artillery shell. So it's hoped that the findings of this project will give us some idea of what we can expect from the likely long-term health problems for today's cohort of amputees and what they might be facing in a few decades' time. So in this systematic review, we were interested in exploring the professional conversation around chronic post-amputation pain and specifically phantom limb pain, and really look at what the medical staff are saying about these conditions, how they're measuring them, how they're treating them, how they're sharing ideas, and the changing theories and etiologies across this time period. So to do this, we did a search of the two major medical journals in the UK, that's the BMJ and the Lancet, for all references to chronic post-amputation pain and phantom limb pain within this specific cohort. And as you can see here, we ended up with 202 texts, with 43 relating specifically to phantom limb pain. And this 43 works out as around 1 in 5, specifically referring to phantom limb pain. That was quite interesting to see because it's double the rate that we see in the patient records, where only around 1 in 10 patients report having limb pain to their medical teams. In terms of etiology, the majority of texts refer to phantom limb pain as being caused by a combination of factors. So, for example, regenerating nerves and the brain struggling to process the body's new shape. Interestingly, there were no reports of malingering or of shell shock, being what we now call PTSD, now being the sole cause of phantom limb pain. Suggesting that when patients did report these symptoms, they were being believed. And if they did report phantom limb pain, there were a range of treatments available. 33 different treatments were recorded across this period. Some have died out, but some would still be recognizable to clinicians today. And we found that treatments came and went in around 20-year cycles. So as you can see here, surgery and needle-based therapies like local anesthesia or nerve blocks were overwhelmingly the most common therapies. And surgeries range from relatively routine procedures like reamputation or the excision of painful nerves or neuroma to more invasive procedures like rhizotomy and sympathectomy, and in one case even endocotomy was recommended. So to sum up very quickly, this systematic review is a constituent part of a wider collaborative project combining research methods from clinical medicine and humanities. As I mentioned, the injury patterns and the prevalence of chronic pain in the First World War and today's casualties are very similar, so it's hoped that the findings of this project will be of use in strategic planning for long-term pain conditions for today's and for future blast injury cohorts. So thank you very much.
Thank you very much for your presentation, and we're ready for our next speaker.
Okay. Wait. Okay. Hello, everybody. I'm Sarah Coppi, and I'm a PhD student at Harrison Lab in Karolinska Institute. So today I'm going to present the preliminary data of my first study of the PhD. Here we wanted to understand if nociceptive signals could integrate with visual signaling and proprioceptive signaling in similar paradigm as the rubber band illusion, but what we wanted to do was a new paradigm that we call the nociceptive rubber band illusion, and here we wanted to limit the tactile signaling, so we use the ND-up laser to try to stimulate just the A delta and the C fibers and the related nociceptors. As you know, the rubber-band illusion is a paradigm used for the body ownership. And in the specific study, we ran 3 experiments, and each experiment had 30 participants. The first experiment aimed to understand the subjective sensation that the participant had. So we delivered the questionnaire, an embodiment questionnaire adapted to the usual one, and we found that in the experimental condition, the experimental questions were higher compared to the control condition. In the first and the second experiment, the condition used were synchronous versus asynchronous. And in the third experiment, instead, there was congruent versus incongruent position of the rubber hand. So, as I said, the first experiment was for the subjective experience, whereas the second and the third experiment were to understand the objectively the body ownership sensation that they had. So we used the proprioceptive drift task in both experiments, and we found again that in the experimental conditions, the updated localization of the own lib was higher compared to the control conditions. And this lead us to say that the multisensory integration between the nociceptive signaling, the proprioceptive signaling, and the visual signaling are important in the same way to build up a coherent sense of self. So said that, I just want to thank everybody in my lab and all the funding that allowed this research. And of course, I want to thank the organizer. If you have any question about the experiments, you can write me an email to sara.coppi@ki.se. Thank you very much.
Thank you very much for your presentation. And with this, we conclude our poster session.